Our fourth speaker in this session is Professor Matt Hickman, who is Professor of Public Health and Epidemiology at Bristol. The modelling work that he's done with his colleague Dr. Natasha Martin has really driven this area significantly over the past few years, and particularly looking his interest in patients or people who inject drugs and what we have to do in order to bring about change there. So, Matt, over to you.
Super. So that makes me an other. Okay. So the first thing I want to say is that if you want to talk about eliminating hepatitis C, you need a dynamic model, because this is a sort of example. So you have a pool of people who are uninfected, they become infected, chronically infected, then you treat them, and if they're injectors, they go back in this pool, then they can get reinfected. So without a dynamic model, you can't really truly estimate what the impact of treatment is on prevalence, unless you take account of the fact that people become infected. But also, if you reduce the pool of infected, you also have a prevention benefit, so you can drive prevalence and incidence down. So you need a dynamic model to show that you can eliminate hepatitis C, which I agree, you can eliminate hepatitis C. So just a reminder of why it's important to treat injectors. There are about 190,000 people with hepatitis C in the UK. The majority are among injecting drug users. If you were to discount people who acquired infection abroad, over 90% of hepatitis C is acquired through injecting. So to prevent hepatitis C in UK, you need to deal with injecting drug use. So this is our sort of elimination model. It's a heat tech model, and it shows as you increase the coverage of opiate substitution treatment and needle exchange, and also as you increase treatment of hepatitis C. So in this area, you are starting to get towards elimination of hepatitis C, where you can drive hepatitis C down by 80%, 90%, and in the orange area, you're reducing it by about half, and down here having very modest impact. So the key thing is that if you want to reduce hepatitis C prevalence by over 40% among injectors, you need to scale up treatment. So treatment is critical. But scaling up treatment and opiate substitution in high coverage infections, you can eliminate hepatitis C. And because this is a slopey line rather than horizontal, as you increase opiate substitution treatment, needle exchange, you have a benefit on incidence. You drive down incidence, and this has other benefits as well. And also, you reduce the number of treatments required to reduce hepatitis C prevalence. So you have a beneficial effect there. You can save resources. That's theoretical, obviously. So what we wanted to do is, well, how many people are being treated at the moment? And we did there isn't really much routine data about people who inject drugs who are being treated. So we did an exercise with 7 sites in which we collated the prevalence of hepatitis C, prevalence of injecting, and also then calculated how many treatment rates were. And we defined injectors as people who were on opiate substitution treatment when they were being treated for hepatitis C, or had evidence of injecting in the last 3 years. And what we found is that there was, at the moment, a fourfold difference in treatment rates among different sites. I mean, embarrassingly, in Bristol, where we work, is about 5 per 1,000, pretty low in London and North Wales. But other sites like Manchester, Nottingham, Plymouth, we're getting up to 20 per 1,000 injectors per year. So what we then did is, well, if we take what the prevalence of hepatitis C is among those sites, and then we project what 10 years of treatment will be on the prevalence, we get this result here. So the blue is prevalence now. In 10 years, we get this ghostly white, which there's very little difference. So this is with pegylated interferon and ribavirin. So, and the uncertainty is due to some of the parameters, especially around the number of injectors in the population. But at the moment, in current treatment rates, you're not going to get an observable difference. But, as Homer suggests, and the other speaker suggests, if you get the new interferon-free DAAs with their improved SVR rates, then you can, even at achievable treatment rates of, say, 26 per 1,000, which is achieved by Manchester, you can halve hepatitis C prevalence in 10 years in most sites, and in Dundee and North Wales, you can virtually eliminate it under actually what we're doing at the moment with these new drugs. We also did previously some work in Edinburgh. So the diamonds here are with a prevalence of hepatitis C of about 25%, 30%. And then current treatment rates there was about 8 per 1,000, and it's dark line here, which suggests very little impact, even with the new interferon direct-acting antivirals, but with quite modest increases in hepatitis C treatment to above 20 per 1,000 or 40 per 1,000, then you're starting to get a 70% reduction of hepatitis C in 15 years, or 90%. So the last slide I want to show is around, well, the targeting of which population should we, as you scale up hepatitis treatment, which population should you target? Now, most guidance suggests that you should start dealing with severe disease, then you go to moderate disease, then you go to mild disease. And we would agree if you've got a population where chronic prevalence of hepatitis C is 60%. But if you've got populations where the prevalence is 20%, which are some sites, or 40%, then the patients that you target may be different. And so what this line here shows is the most cost-effective form of treatment in the patients for 20%, either with the old drugs or with the new drugs. And if you're on this line, that's the most patients you should target. If you're this side of the line, it's less cost-effective. So if your prevalence of chronic Hep C is about 20% in your population, then you should be treating injectors. You should be treating injectors with moderate disease and even treating injectors with mild disease before you treat other population groups. If you've got a chronic prevalence of about 40%, like London and some other sites, then you're still treating injectors with moderate disease because of the prevention benefit, and then also closely followed by people with severe disease. So we agree you can reduce hepatitis C prevalence in the population through scaling up Hep C treatment, but also don't forget the effect of opiate substitution treatment and needle exchange. We agree that you need to optimize reduction of end-stage liver disease as well as the prevention of HCC transmission, but you need a dynamic model to really determine what the local and national targets are, because other models might overestimate the number of treatments you need. Thank you very much.